We have to
We have to move.
Yeah.
Good evening. Hello.
Hello.
Hello
Everybody.
from me too.
Can you hear me?
Good evening.
Hello, hello. So we
these
are
are Dr. Iliodromitis and Dr. Kostopoulou, our best friends and two people who are dealing with electrophysiology with great, let's say, past and presence in electrophysiology. And we would like to have their opinion about this session, their thoughts about interventional CMR. So, ladies first. Dr.
Ladies first.
Kostopoulou.
Okay. Okay. Good evening to everybody and dear professors. Sophia, thank you very much for the invitation. Now, this was a very interesting meeting because it had a lot of information, a lot of new things that are coming in front. For me, MRI is visualizing the substrate. So it's very important to have advances in this field. And it was very nice to see that apart from diagnosis, we have progress in therapy, in targeting biopsies in areas of interest and having less negative results, to ablating, because it is, we are creating a new environment, I think, for the future EPs, a non-X-ray environment for the next generation. And I think that EP is a difficult field, and I find it very difficult for us to be replaced by other specialties, to be honest. I think this field is really difficult, even for the ones trained in EP, and I find it very difficult to be out of this conversation in the future. I think the EP doctor will always be in charge of an ablation procedure. That's because just a remark of the previous discussion. I would like to ask Dr. Petropoulou, which made a very nice presentation, about the devices, a question about the devices that automatically recognize that they are in an MRI environment and change to MRI mode. Do we trust them? There's a German brand that has created devices that you don't need to test the device before they go into an MRI, and it changes to MRI mode. Do we trust the devices, or do we have to do a test? And the second question is, have we thought about the legal consequences of performing an MRI, in a non-conditional device? If something is labeled non-conditional and something goes wrong, who has the legal consequences? What happens? Because it's easy to say, I can do it, and it is probably safe, but it is not labeled as conditional. So legally, I do not think we are allowed to perform an MRI, except if it's for a life-threatening condition. That was how.
I think the question is for you, Sophia.
It's a question to all of you.
Yes, but I'm sorry, but I missed the first part because I was
the first part was
sorry, I'm so sorry.
Of the devices that automatically go into an MRI mode by Biotronic. They have developed devices that you do not have to program the device. It recognizes that it's in an MRI field and it changes to MRI mode.
Okay.
Do we trust them, or do we have to test them before, like we do in the other devices?
Well, this is why the guidelines are very strict, that the protocol has to be followed, that we have to do the original test, that we have to recheck. And as for non-conventional devices, yes, studies show that in theory it's not unsafe, but the protocols in the European societies, for example, protocol on how to use, it's very strict. It's a 2B recommendation for non-conditional devices under very strict protocols. So yes, it does not mean that we are ready to say to non-conditional devices they're just free to enter the MRI scan under no supervision. Yes, I agree.
I think we should know whether this device is approved by EMEA and FDA. If the device is approved for this function by FDA or for Europe for EMEA, then you can use it. And then the liability is with the manufacturer. But if it is not approved by these agencies, then you're off-label. And if you scan off-label, so if you scan non-conditional device, then you are responsible. And it's not the referring physician which takes the responsibility, it's the one who performs the scan. So if you scan a non-conditional device and you have a complication, it's your fault, and you will be on court in the worst case.
Okay.
And of course, FDA and EMEA, they would only approve automatic detection of the magnetic field if there is a decent study done by this company. So they should do a study with two arms. One arm is 1 hour on the bed, none in the MRI, check all the thresholds. One arm is going 1 hour into the MRI, check all the thresholds, you come out, and then you compare. So you must have a control group that doesn't go into the MRI, but it's 1 hour on the bed, and one real group that goes into the scan for 1 hour, goes out, and then you see whether there is a difference. And this is costly. But of course, if you want to go to the market, you have to do that.
So let's ask Dr. Iliodromitis, any thought about CMR conditional devices or any other issue in electrophysiology? How do you find the idea of performing
lots of thoughts, actually. Thank you thank you very much for the invitation, Sophia. I'm very happy to see you again. It was an excellent organized session and congratulations also to all colleagues with their presentations. They were very interesting and informative. I must admit that myself, I'm having no experience with electrophysiology in MRI environment. The only thing that I can say from my point of view that I'm seeing in the electrophysiology currently is that we're having an increasingly number of patients that need to be treated invasively, especially patients with atrial fibrillation. We're having a severe change in the demographics currently, which are going to put lots of pressure in the healthcare system and costs. And I think that it looks to me currently like we are shifting from the one type of energy globally, I mean, from using fossil fuel, which is the current way that we're doing EP with fluoroscopy and the 3D images, going to renewable sources of energy, which that are very nice and clean, but I don't know if they are enough on their own to cover the needs of current cardiovascular invasive treatment. I like very much the thought that having zero radiation, I like very much the thought that I don't need to carry a lead during a procedure. However, I'm having zero fear that the radiologists are going to take over, not because they can perform electrophysiology, but I think that a very big amount of the diagnostic part of the radiology is going to be taken over by artificial intelligence. My concerns are, first of all, how wide applicable it can be, not only in university centers and in countries who are having the resources to perform these procedures and have an MRI dedicated device for EP only. This is a crucial factor. Second, how in reality the learning curve for each different electrophysiological procedure, how fast it is and how effective it is, because it was very nicely presented with the atrial flutter, how we can see the anatomy, how we can maneuver the catheter. However, this is still one of we're starting with the easiest ablations, but this is the easiest ablation, and this is not the high volume of patients that we are treating. The high volume of patients are patients with atrial fibrillation and complex left atrial tachycardias after failed first ablations. I mean, this is what we see in reality. And I believe, or I would like to ask also Professor Sviter and also the colleagues who are currently in the panel and having experience with electrophysiology in MRI environment, how this is going to be set, because I think the reimbursement of the procedure and the effectively what is remaining as net profit for the hospital, this is going to define if this new environment for electrophysiology is going to carry on, or it is going to remain, like it was previously said, for research reasons only, and in limited amount of centers who are having the resources to do that. Because the high volume that we are seeing in everyday practice, it requires fast availability in the cath lab, short time procedures. The most expensive time, I remember when I did the DASCAM that Professor Hendricks said, the most expensive time in the cath lab is the time we are occupying the cath lab for a procedure. So actually, I think it is very nice, the MRI, and very nice what everything that has been shown. Personally, I see, apart from the problem of radiation, the rest with the current technology that we are having, the 3D systems, the intracardiac echocardiography in such cases, they are offering a very, very pleasant environment for the electrophysiologist. Lots of colleagues are using zero fluoro in most of their procedures. These are my thoughts. I think it's going to be mainly financial and time-dependent factors that they are going to allow the MRI environment for EP. I don't know what is the opinion from Professor Sviter and from the rest of the colleagues who are known and having experience with MRI environment patients. I mean,
yeah, I think it's a very good question, and economical considerations are absolutely key at the end, whether the technique will go into the field or will not survive, or whether we can apply it. I think one important advantage of interventional MRI is that we can assess the patient and the tachycardias, the lesion where we want to burn. All these factors can be done beforehand. So in the ideal case, the patient would go into the scanner and we know beforehand exactly what to do. You can even do the ablation in a specific patient outside, like in the simulator that I showed you. You can load the heart of that patient, the scar of that patient, and the electrophysiologist who will be in charge of this procedure, he can go to the simulator, he can test with which angulation he can go there, should he go from this side. He can do the whole procedure outside the machine room, outside the MR, and if he knows exactly what to do, where to burn, then the patient will go in and you start the treatment. I think in the ideal case, maybe in a year or 2 or 5, the diagnostic part is not anymore a component of the procedure. You just start with the ablation. I think that reduces quite a lot of time. And I mentioned this study in Barcelona where they used scar distribution overlaid on the carton map to know where to burn. Even with this transitional phase of using MR data in the conventional lab, they could show that the interventions were much shorter RF application time and less relapses. With the suboptimal setting of only using an overlay of MR data and not really working in the MR environment with the MR data. So I think procedures will be shorter, which will reduce costs. Relapses will be rare, so this reduces cost. The diagnostic part in the lab will not take place, so this will also reduce costs. And you mentioned nicely that we should prepare then the next generation. I think people can train now with virtual reality simulators, so they will be quite effective from the first day they are there. So I think, of course, working in a real environment with real patients will never be replaced by training on simulators. But I think the learning curve, the first part can be taken over by working in simulators. So we can train many more electrophysiologists, which will stay shorter in the MR room for the same procedure. That's the theoretical advantage. Yeah.
Thank you very much.
So anything else we have to discuss? So if there is nothing more, I think we have to end the discussion, end the session, and thanks a lot to all the participants, all the speakers, chairpersons, and also Imricor who supported this workshop about interventional CMR. It was a real surprise for all of us to see all these clinical implications of this new modality, new approach. So tomorrow then, thanks. Good night.
Thank you very much.
Thank you, everybody.
Congrats.
It was a pleasure.
Bye-bye.
Thank you. Bye-bye.
Bye.